Maternal mortality refers to the death of a woman during pregnancy, childbirth, or within 42 days after the end of a pregnancy from causes related to pregnancy or its management. Although global maternal mortality rates have declined, the burden remains highest in sub-Saharan Africa and South Asia. How do we reduce the burden? Dr. Natasha Oibo, founder, Ariely Foundation, will speak to us. Thank you so much for joining us on Insights.
Thank you very much for having me.
Thank you. Now, Nigeria is set to record the highest number of related deaths from maternal mortality.
Yes.
What are your thoughts?
Globally, women die during childbirth. However, Nigeria has one of the highest maternal mortality rates, and that is unacceptable. We account for the highest percentage of the global burden of maternal mortality. And the issue here is that these deaths are preventable. These deaths are highly preventable. These statistics are not just statistics. It is our mothers, futures cut short, women that never would get to live their lives with their children and their families. The causes of these deaths: there are direct medical causes. We have from hemorrhage to obstructed labor, preeclampsia. However, these medical causes are preventable. We have limited access of these women to infrastructures, to needed care. We have inadequately skilled healthcare workers available to our women. There's several causes that lead to maternal mortality, from direct to indirect causes, including socioeconomic factors.
Okay. Now you've given us some of the medical factors. What are the social and economic factors that contribute to this persistence of this problem?
Okay. I would say poverty,
Okay.
low health literacy. Availability of information is very important. For the woman to decide that she wants to get to care, she has to know why she needs care. Sensitization. There are a lot of socioeconomic factors. We have cultural norms, cultural barriers, gender norms, infrastructure, weak infrastructure, inadequate infrastructure, weak health systems. We also have inadequate funding. So there are several factors that contribute to maternal mortality.
So what strategies could be adopted or implemented to reduce its prevalence in Nigeria?
This is multifaceted.
Okay.
One stakeholder cannot handle this giant alone. We need help from the government in terms of funding, policies, budgeting, gender responsive budgeting, gender mainstreaming when it comes to budgeting, procurement. We need the government to allocate funding, heavy funding for maternal health. We also need stakeholders like the NGOs, the CSOs, community actors to come together when it comes to community engagement, when it comes to sensitization. Our women, especially those in the rural and underserved areas, they need sensitization. They need to be engaged with. We need to engage with traditional birth attendants because these women, they see them as the first point of contact. We need to integrate them into the system. All I'm saying basically is that we need to come together. Collaboration is the key. Identifying the key players and stakeholders in this fight against maternal mortality is the key.
Okay. Before we talk about what your foundation has been doing in this regard, you mentioned gender responsive budgeting.
Yes.
Why are we not leveraging this?
I would say when it comes to the policy level, in as much as we understand the word gender responsive budgeting, I think we also need to inform and educate our policymakers, the people in charge of budgeting, on gender-responsive budgeting. We need to bring key stakeholders to the table in order to analyze the budgets and see the benefits to women, what are the benefits to children, gender equalities when it comes to budgeting. And that way we would start to understand, okay, women needs more, would I say, sanitary towels, for example, in the toilets, free, in the public toilets. You start considering, start thinking of the women.
Now, back to maternal mortality. Yes. What actions is your foundation taking to support maternal and newborn health and prevent complications? What are you doing?
We go into communities, grassroots communities, communities that we see as rural and underserved, IDP camps. We carry out community sensitization, engagements. Information is key. These women need to be informed. There are several delays that lead to women dying during childbirth or during the pregnancy period. And such delays, the first one is delay in actually identifying that you need care. So we're tackling that by going and saying you need care. You need to be informed that you need to go to the hospitals at the first sign of pregnancy to identify with your doctors and say, oh, I'm pregnant and can I start my antenatal services? So that's one aspect, and there's a delay in reaching care. There is, we don't have an ambulance system that even serves the underserved areas. So we're coming up with new innovative ways to tackle that delay. For example, we're trying to work with the National Union of Road Transport Workers in order to incorporate them in the ecosystem to say, okay, within the community, if a call line is set up within the community and the Union Park, if the ambassador in the community, a really ambassador in the community, identifies at the first sign of risk that a woman is dying or a woman needs care, she then puts a call into the National Union of Road Transport Workers, the community chairman at the park. Then they send any available taxi driver to the community. So such sort of interventions and thinking outside the box, because we can't continue to go the normal way. We have to disrupt the normal way of doing things, because it's not possible for us to give every community a well-functioning ambulance. And if it's possible, that would be good, but we know that it can break down and they don't have the money to fix it. So with limited resources, we now started thinking, how do we make things different? So that is for the aspect of delay in reaching care. And we are starting to also work with the primary health care centers, because they need adequate training as well. The workers, the nurses, they need training, they need more training, they need donations for materials. And we are also incorporating the native midwives and the traditional birth attendants that we find in communities within these communities. We're trying to incorporate and integrate them into the mainline system so they can work hand in hand with the primary healthcare centers, especially for referrals, because the key to saving a woman's life is time. When the woman comes to the native midwife whom she trusts, and the midwife doesn't understand that you need to refer this woman straight to the hospital, then that is a problem, because she will die there. And so training and telling these traditional birth attendants, these first sort of gatekeepers in the communities, that you need to identify risk and then refer. So there's the referral system, the engagement, the education, innovation, research.
The traditional birth attendants have always been there. Yes. For women in rural areas at the grassroots, attending to their birth needs. But now the issue is this: some do not actually go to the hospital. Some do not have access to the hospital. Most women depend on traditional birth attendants to help them deliver their babies. But some are actually still at home. So how do we engage traditional rulers in this area to ensure that we reduce the prevalence?
Okay, traditional leaders, we see them as gatekeepers. Even during our community engagements, we first of all go to the traditional leader of that community to seek permission. And we find that once they give us a go-ahead, it's easy for us to start talking to the individuals in the community. So we see that they are very important when it comes to engaging with the community, engaging with whomever we see in the community. The traditional leaders are very important because when they say go, the women, everybody obeys. So engaging them in this fight is very important because they tend to pass on instructions to the religious leaders, the non-religious leaders, the community leaders, and then this information is cascaded down to the little people. This information is cascaded down to the people in the community. So I think they're very important, and also when it comes to the inclusion of men, because they're very important in this fight. So including traditional leaders, including men, you tend to see changes. You tend to see changes in decision making because the men have a lot of power when it comes to decision making in the lives of the women, especially during this pregnancy period or before the pregnancy period, or when it comes to family planning, the men are important. So if we incorporate the traditional leaders, incorporate the men within the engagement, we tend to see that things move swiftly and very easy for us during our engagements.
Considering the global goal to eliminate maternal mortality before 2030, realistically, from a stakeholder like you, someone championing the cause of the Nigerian woman, is achieving this goal feasible?
I would say it's a very ambitious goal from what we on ground are seeing. It's very ambitious, but it is every step towards the right direction matters.
Okay.
We should aim for it. Getting less than 70 per 100,000 live birth from the current situation where we are is very ambitious for 2030, but I feel if we have our roadmap clearly set, if we have our strategies clearly set, we would achieve a lot. We would save a lot of lives. It's not just about the race to get into less than 70 per 100,000 live births. It is about every single life we save, every woman that we give I would say we give the gift of life basically, because when a woman is pregnant, her life is in God's hands, it's in the hands of the medical, it's in everybody's hands, in fact, all the stakeholders. We have a duty to take care of every pregnant woman in Nigeria. So getting to that point where we have less than 70 will be the ideal, but it is very ambitious, and I think we just need to do more. We just need to have a clear strategy, bring in stakeholders that care, stakeholders that understand the issue to the table. Our policies should reflect our realities, and our policies in a lot of places are not translating. So we need to go back, look at our policies, and then understand why they are not translating to the underserved, rural, neglected areas. We need to go back to the box and think innovatively, because if we do not start thinking outside the box and innovatively, we would not achieve close to our target in 2030. We would still be where we are, and that is unacceptable, because these deaths, like I say, are preventable. Our local government chairmen, they need to understand the need for the primary healthcare centers to be fully funded and equipped. We need to inform all the stakeholders, have information sessions, constant communication with the government to say, this is what we need as the community actors. These are the pain points of these women. We need to just get to the pain points. When we get it, then we would start seeing real progress. When we get it, then we will start saving lives every single day.
We'll start saving lives. Dr. Natasha Oyibo, I want to thank you so much for joining us on Insight, and thank you for enlightening the Nigerian woman. Thank you very much.
Thank you so much.
Thank you.
And that's it on this segment of Insight. We'll see you again same time next week for more on the program. My name is Nnamdi Odipo.
And I'm Elizabeth Omori. We'll see you next week.
Best of the season to you.